Good morning, everyone. Today's paper presentation is on imaging spectrum in epilepsy in pediatric age group. The presenting author is Dr. Pavan Krishna, a radiology resident from AJ Institute of Medical Sciences. My co-author is Dr. Kailas, a senior resident, AJ Institute. Uh, Coming to introduction, pediatric epilepsy represents a significant and a complex aspect of childhood neurology characterized by the occurrence of abnormal neuronal activity due to excessive or unsynchronized electrical discharge resulting from abnormalities in the inhibitory or excitatory pathway of the CNS. The global prevalence of epilepsy is estimated to be approximately 0.5 to 1%, highlighting its prominence as a common neurological disorder in children. A seizure is defined as a paroxysmal electrical discharge from the CNS, resulting in involuntary motor, sensory, or autonomic disturbances with or without al alteration in the sensorium. Coming to aims and objective, to evaluate the pattern of imaging findings, especially MRI in children between 1 to 18 years with epilepsy, to determine and characterize brain lesions underlying epilepsy and possible etiology in pediatric patients. Coming to materials and methods, this is a retrospective study. The data of this study was obtained from the radiology department of AJ Medical College, Bangalore. Images were reviewed on the hospital PAC system. Inclusion criteria is 1 to 18 years, diagnosed with epilepsy or presenting with seizures, availability of complete clinical details, and the imaging sequence. Exclusion criteria is children with contraindications to MRI with metallic implants or pacemakers, incomplete clinical or imaging data, poor quality or non-diagnostic MRI scan, and patients with acute trauma-related seizures, where seizure etiology is distinctly non-epileptic. Coming to the protocol, it consists of comprehensive high-resolution imaging, including 3D T1 weighted sequence, and thin slice coronal imaging perpendicular to the hippocampus to detect subtle lesions, such as hippocampal sclerosis and cortical dysplasias. The multiplanar T2 weighted images and T2 are used for detection of structural abnormalities, including malformation or cortical development, gliosis tumors, and post-infectious or post-ischemic changes. Adjunct advanced sequences like DWI for acute pathologies, SWI for microbleeds or cavernomas, and optional techniques like DTI, MR spectroscopy, and functional MRI for surgical planning and characterization of the epileptogenic zones. Coming to the results, in our study, 93 children who were diagnosed with epilepsy underwent MRI imaging of brain. In this, 67.7% of them had normal findings, and 32.2% shows spectrum of abnormal findings with the structural or congenital abnormalities in 11 to 11.8%, and hypoxemic, ischemic, or vascular causes in 8.6%, sclerosis or degenerative causes in 3.2%, metabolic toxic causes in 3.2%, infectious inflammatory or autoimmune causes in 3.2%, and neurocutaneous or genetic syndromes in 2.2%. In our study, structural or congenital brain abnormalities was found to be the most important etiological factor, followed by hypoxic injury or vascular causes. It was also found in our study that the most affected were males, and the most commonly affected age group is 9 years. This is a case of cytotoxic lesions of corpus callosum in the splenium. Here we can see ADC signal drop in the splenium with hyperintensity on DWI sequence. This is a case of cortical dysplasia. Here we can see abnormal chiral pattern involving the right frontoparietal regions with prominent right lateral ventricle. And in the third image, we can see the mesial temporal sclerosis, where the right hippocampus shows mild volume loss with subtle hyperintensity. This is a case of craniopharyngioma, which shows solid cystic lesion in the suprasellar region, uh, which shows a mild peripheral enhancement on post-contrast study. This is a case of encephalitis, where we can see hyperintense signal on bilateral thalami on FLAIR and T2 weighted images. And the third image shows pineal cyst on the T2-weighted sagittal images. This is a case of posterior reversible encephalopathy syndrome, where we can see gyral edema with hyperintensity in the parieto-occipital lobes. Coming to the discussion, uh, in our study, showed a lower MRI abnormality rate of 32.2%, mainly structural or congenital anomalies in 11.8%, and hypoxemic, ischemic or vascular causes in 8.6%. The Ugandan study, where 147 children reported a much higher abnormality rate of 74.2%, with acquired abnormalities predominating, especially hippocampal sclerosis, along with congenital abnormalities like HIE, PVL, and cortical developmental disorders. Differences between the two cohorts likely reflect regional, clinical, and methodological factors, including referral pattern, imaging thresholds, and seizure type distribution, which influence imaging yield and etiological profile in pediatric epilepsy. Coming to conclusion, in these studies, MRI detected abnormalities in about one-third of pediatric epilepsy cases, with structural congenital anomalies with hypoxic, ischemic, or vascular causes being the most common etiology. Findings highlight the critical role of MRI in identifying clinically meaningful causes of epilepsy, and show how geographic, clinical, and methodological differences influence the neuroimaging patterns seen across the population. MRI remains the modality of choice due to its high resolution, multiplanar capability, and lack of radiation, making it essential for early diagnosis and guiding timely, appropriate treatment in pediatric epilepsy. These are my references. Thank you.